Hi, I've made some videos to help you prepare for our upcoming session on bradycardias. This is the first one and will mainly deal with determining which P waves are conducted and which are not. Conduction issues may seem a bit dry, but they're at the heart of ECG interpretation. So far, we've laid out a framework for thinking about pathology that the ECG signals. Under the immediate action heading, we've dealt in depth with identifying occlusive ischemia, and we've dealt with identifying potassium derangement, sodium channel blockade, and other issues affecting the QTC. In the course of dealing with these issues, we've dealt with things that are problems, but that we potentially have more time to deal with, such as structural issues and issues predisposing to sudden VFib death. We're also going to get to other markers of acute illness. But the time has come to deal with the one thing that all of these other problem categories can manifest as: conduction issues. I'm using conduction issues to refer to instances where atrial signals are not conducted by the AV node, the ventricles, or both. Before approaching abnormal conduction, let's look at a normally conducted beat. The signal starts in the atria at the SA node, then gets conducted by the AV node. There's a pause at the AV node, then it's conducted by the ventricles. The question when we're looking at an ECG or a telestrip is whether atrial signals are being conducted like we just saw, by the AV node and then by the ventricles. There are really three possible answers. All are, as we'd see in normal sinus rhythm. Some are, as we'd see in second-degree heart block, or none are, as we see with the AV dissociation associated with complete heart block in VTAC. Having observed normal conduction, how do we identify abnormal conduction? The short answer is we identify non-conducted P waves, that is, blocked beats. A non-conducted beat is generally one where you see a P wave indicating an atrial signal and atrial depolarization, but you don't see a QRS following it. As you may notice above, this can result in the appearance of consecutive P waves. When I'm scanning a rhythm strip looking for non-conducted beats, I look for consecutive P waves. The diagram I've just revealed is called a laddergram. It uses lines to show signal conduction and blockage at different levels. I will explain them in another video. To recap again, in complete block, in VTAC, these non-conducted P waves reflect AV dissociation, independent atrial and ventricular pacemakers. Atrial impulses are not being conducted by the ventricles. In second-degree AV block and atrial flutter, impulses from the atria are occasionally conducted and occasionally non-conducted, and this often occurs in a periodic manner. We also need to account for hidden P waves, and we need to account for whether non-consecutive P waves are conducted or not. We'll go through this now. When you've seen me holding calipers to a computer screen before, you've probably seen me looking for hidden P waves by marching the interval. Here's how it works. We identify consecutive P waves. We use them to establish a PP interval. We move the PP interval backwards and find another P wave. Then we move it backwards and find another one, but this time it's buried in the T wave. Now let's move forward from the pair of consecutive P waves we found, and we find a P wave buried in a QRS. Before we go on, scan the strip and ask yourself which, if any, of these P waves are conducted. There are 6 R waves on this strip. Only one of them has a normal associated PR interval, and that's the third one. That also happens to be the only conducted beat. So we found all the P waves, and now I'm going to reveal the ladder diagram constructed by Dr. Wang, Hennepin cardiologist. I'm going to talk about how we could talk about this tricky rhythm with cardiology before we're done. But first, we need to determine if a beat is really conducted. To determine if a beat is conducted, looking at the PR interval is a good place to start. Trickily, really long PR intervals can be associated with conducted beats. As a reminder, the PR in first degree block is over 200 milliseconds, and over 300 milliseconds is an indication for IV antibiotics and Lyme disease. If you see a normal PR interval, assume that the beat is conducted. Now, however, we're going to discuss something new. Earlier, I emphasized that a normally conducted beat is associated with conduction by the AV node in a pause, which corresponds to the PR interval. Accordingly, if there's no pause, if the P wave is adjacent to the QRS, suspect that the beat is not conducted. The adjacent P with a delta wave is associated with pre-excitation like Wolff-Parkinson-White. The adjacent P without a delta wave is probably just not conducted. At the very least, it's pre-excited. When you get down to it, our job in analyzing ECG rhythms with blocked P waves can be pretty simple. Find the P waves, then figure out which ones are conducted, and figure out which ones aren't. If you can do this, then you can often make rhythm diagnoses based on the regularity of the P waves and the QRS complexes. And if you can't, you can at least discuss the ECG intelligently with cards. And here's the secret shortcut principle, one cool trick, if you will, for doing so. The regularity principle. If there are some blocked beats, the more regular the PP intervals and the more regular the RR intervals, the more concerning the rhythm is. Let's apply the principle I just introduced to discuss this very tricky rhythm. Don't get freaked out because there's some stuff we'll be touching on that we haven't gone over yet. We have already determined that there are regular P waves, one of them is conducted, and the rest are blocked. But what if that P wave isn't conducted? There's definitely a lot of AV dissociation. Is this complete heart block? Let's turn to the QRS complexes to answer this. They are almost, but not quite regular. The interval between the second and third R wave is slightly shorter than the other intervals. Complete heart block is usually associated with perfectly regular R waves. Dr. Wang deduced from this strip that this is a 2-to-1 AV block. I'll never expect you to be able to do this. What I could have done, and hope for you to become able to as well, is say, this is a narrow complex, nearly regular bradycardia with AV dissociation and maybe one conducted beat. Given the amount of AV dissociation and the high burden of blocked P waves, I'm worried about complete block versus another AV nodal block that might require a pacemaker. Here's a chart showing the intervals in different AV blocks, illustrating the regularity principle. We'll go over this later too, don't worry. It's also on your sheet. In first degree AV block, all the P waves are conducted, and the PP intervals and the RR intervals vary some just like they do in sinus rhythm based on vagal influences. In type 1 second degree or Wenckebach, the RR interval shortens until there's a dropped beat. In type 2 second degree block, which is below the AV node, the vagal influence is lessened, so PP and RR intervals are more constant. In complete heart block, there's no vagal influence on the QRS generation, so the RR intervals are totally constant. So here are the big points from this video. First, to find the blocked beats on your quick rhythm strip scan, look for the consecutive P waves. To find the rest of the P waves, take that consecutive P wave interval and march it forwards and backwards. Third, when you see adjacent to the QRS P waves, assume that they're not conducted. Finally, given some AV dissociation, given some non-conducted P waves, the more regular the PP and RR intervals, the more concerning the rhythm. More to come on this.